I'm Mike Khadavi, PM&R Sports Physician, Fellowship Director for the MU Sports and Orthobiologics Fellowship, and President of TOBI. I want to genuinely encourage everyone with any level of interest in orthobiologics to tune in to the BIOS KOL Sessions. I can't think of...
Subscribe now! Welcome back to another BIOS KOL Sessions. Today we're going to be diving deep into intraosseous injections. I have a great pleasure of introducing El Presidente from TOBI. He's also the Fellowship Director at the University of Missouri for the first Orthobiologic and Sports Medicine Fellowship. We'll talk a little bit about that. But honestly, just a great person, great dude, someone I truly value his opinion on everything. Dr. Michael Khadavi, thank you for being here.
It's an honor to be here. Big honor.
So what's up, man? How you doing? Are you excited for TOBI? You know, we're going to get going here in a couple of days. How are you feeling about it?
Good. You know, it's the best conference there is. It's always something to learn here.
Sure. Now, how was the prep? I know that people sometimes don't realize they just show up at the conference and then everything kind of works. How is the prep into one of these, big meetings where like everybody's flying from different countries? You know, we're meeting here. We got to make sure everything's set. How was that process?
Yeah, a big learning experience for me over the last few years that I've been heavily involved with TOBI. There are always people who last minute can't make it.
Sure.
Some of them are international, and we've been prepared with someone to back them up at the last minute. But overall, smooth.
Good.
Just more work than I would have expected happens behind the scenes.
Sure. Well, we'll get into the topic a little bit. Before we go right into I.O., tell us a little bit about the fellowship. What makes it unique is we discussed that this is the first academic-based orthobiologic fellowship. I'm so proud of you for that. Thank you for doing that. Tell us about it.
Yeah. The fellowship started as a sports fellowship, as a sports medicine fellowship, because my practice were fortunate to have really strong, highly trained, academic-minded and practically minded sports orthopedic and sports physiatry physicians. So what we found was that in sports medicine fellowships around the country right now, they just simply don't have the opportunity to get the training they need in orthobiologics. And so when we were creating this fellowship, one of our ideas was, well, do we just take postgraduates who have already done a sports medicine fellowship and at that point give them a 6-month booster on orthobiologics to learn intraosseous, intratendinous, how to figure out your platelet doses, all those little details that are simply not included in the majority of our fellowships. And so we decided to just combine it all into one. So fellows can come in after residency, straight from a residency, or they can come in from a sports fellowship. And it's 12 months. Amazing. And it is, we have all the resources from University of Missouri and all the resources from our 42 physician orthopedic group in Kansas City.
That's awesome.
For everything, research, sideline coverage. They have several professional sports in Kansas City that they get to be a part of. And then there are several of us who have heavy orthobiologic practices that they get to join.
That's amazing. Can I apply?
Well, you're about to be asked to lead a virtual discussion. So,
all right. Well, here we go. Yeah. All right. So I.O., obviously a very big topic right now, intraosseous injections. You know, we've started more with intraosseous bioplasty, which may be a tad bit different, or specifically talking about going in and decompressing a lesion and then creating a bone graft, which is, PRP bone marrow with bone graft and injected in. And we've kind of modulated that to now doing in-office intraosseous injections of bone marrow concentrate or PRP. So, kind of what was that moment for you like when you said, hey, I'm ready for this, or hey, this really makes sense? How did you get into this?
Yeah, well, first off, I want to make sure anyone listening knows I've known Alberto for a long time. We did some of our residency interviews together in 2008, 2009. Then we did some of our fellowship interviews together.
That's crazy, yeah.
2012. We started our fellowship in 2013. And I'll never forget following you in fellowship interviews where the interviewer, very high-ranking, world-renowned sports attending, went over. So I only had 15 of my 30 minutes to talk to that attending. And then the first 5 minutes, they just wanted to talk about Alberto.
That's crazy.
It's true. It's true. That's what happened. And so, but our relationship is interesting because we learned a lot of this stuff together.
Absolutely.
We came out of fellowship at an amazing time in 2014 where we learned ultrasound in our fellowships. This didn't happen before that. And we both got a smidge of orthobiologics in our fellowships. I worked with several big names at Stanford when I was in my fellowship. And then coming out, we reconnected a couple years later teaching courses together. And Luca Podesta was my greatest mentor in orthobiologics since I left my fellowship. And the three of us learned, developed skills, taught each other a ton of stuff together. My first intraosseous case was in 2017.
Wow.
Before the randomized trials came out. We had some technique papers. We had some case series. We thought it worked. I did my first case with moderate enthusiasm. My first case did phenomenally well. It was a severe arthritic knee that had failed everything else. We had no other options. This individual had some risk factors that kept her from a knee replacement. We did intraosseous. She did phenomenally well. That's just case of one. Not too exciting. We did a couple more. And then very quickly in 2018, not just one, but two randomized trials came out. The anaGO study, the SU study. Both of them very positive studies.
Yeah. The anaGO one was kind of game-changing for me. I agree.
Yes.
Now, how did you, sometimes you read the papers, right? But then how did you get kind of the guts to say, hey, I'm going to do this in the office in an awake patient?
It was Alberto. It was Alberto and it was Luca.
Yeah.
It was the two of you talking together. And boy, the timing of us getting out of fellowship and having pretty good experience by 2017, 2018, the time those randomized trials came out, those studies were done in the OR.
Yeah.
And they were done with some techniques that are not particularly practical or feasible. And so it was really up to us to figure out how do we make this practical in something that is very accessible for our patients with great or even better outcomes. And so a lot of those little tidbits came from our discussions, meeting up 6 to 8 times per year in 2017, 2018, 2019 at various courses and conferences. We taught so many courses side by side. And we'd be in the back of the room talking about stuff. And then we have lunchtime and we talk about stuff. And then we'd hang out afterwards. And there are so many little technique details. Oh, I could give you several offhand of ideas that you gave me or things that you taught me to do. And so right now in 2025, clearly we're at the tip of the iceberg for intraosseous treatments.
Now, the studies you mentioned, anaGO and SU, those are knee arthritis studies. There will be a link below. Click on it. It'll take you to these studies that we're talking about. Is that your main indication right now? What is your main indication, and is that it? Like reactive bone marrow edema for knee arthritis?
The indications that I go by are arthritis of about any grade, fracture non-unions, or a fracture that's a high risk with some reasonable probability of not healing on its own. And then the third indication, besides arthritis and and fractures, is subcortical edema for a tendinopathy at a tendinopathy insertion site. And the reason is the enthesis includes that subcortical bone also, and there is some decent evidence that addressing that will strengthen the enthesis. So going back to arthritis, I first started doing intraosseous procedures only on severe arthritics, and they did pretty well. And then more studies came out that not only does it work better for severe arthritics, but intraosseous works better than just intra-articular injection for the knee in mild and in moderate osteoarthritis. So I expanded it to all of those, and when and how often we recommend it. There's much of an art to it, And I might be a little bit on the shyer side with recommending for more mild and moderate arthritis, but when it comes to my own body, the question is, what would I do? Of course, I would go intraosseous because it works better. It's going to slow down the progression of arthritis. And in 15 years, my arthritis would be less than if I hadn't done intraosseous.
I agree. Now, what is your biologic of choice? Is it PRP or bone marrow concentrate?
For intraosseous use, there is some evidence that bone marrow concentrate is superior. Not enough for me to say definitively, but the intraosseous studies that use bone marrow concentrate, they have longer follow-ups, 15 years, whereas the intraosseous studies with PRP are between 1 year and 2 years. So we have stronger data for intraosseous with bone marrow concentrate. There are a couple studies that compare the two of them, either in vitro or in animals, and they show that the bone marrow concentrate has more pain reduction and slows the degenerative process more powerfully than PRP.
Yeah,
That's why BMC is my preferred choice.
Yeah, I'm in agreement with that. I feel like, especially earlier, some of the bone marrow work was more consistent than PRP. And to me, it's more apples to apples, right? You're injecting kind of a like-to-like substance. Now, let's say if we are going PRP, is there a specific platelet dose that you like to go to? And B, we always have the leukocyte-poor, leukocyte-rich. Yeah. If you want to break it down to monocyte neutrophil, sure. Yeah. But, what's kind of your thought process? Let's talk about one, reactive edema, and two, non-healing stress fractures. Are you going to change what you put in there? Kind of what's your protocol in your head to pick the biologic?
Yeah. So first off, I don't think we know leuk-rich versus leuk-poor for PRP. I don't think we know cell counts for bone marrow concentrate. We have some very early studies, but nothing definitive at all. I don't think we know platelet counts, but I'll tell you what I do. I generally dose somewhere between 2 and 3 billion platelets per milliliter. Yeah, so that's 2,000 platelets per 2 million platelets per microliter.
Yeah.
And at that point, it's a volume question for me. So that's my baseline. For my total nucleated cell counts, for my bone marrow concentrate, I want it somewhere between at least 100 total nucleated cell counts, which is a surrogate marker for mesenchymal stem cells. Now, my volume, I've played around. I started 10 milliliters per large bone of the knee. A lot of us did. Hernagu's studies, that's what he used. So if we really want to quote his studies and try to recommend a procedure based on his studies, we should probably following those numbers. Since then, I went down on my volumes per bone, such as medial femoral condyle, medial tibial plateau, from 10 milliliters to 7 to 5. I got down to 2 per bone, and now I'm back up to somewhere in the 5 to 7 milliliter per bone. For a patella, 3 to 4 milliliters. For small bones at the foot, sometimes it's 1 or 2 milliliters. Same with the wrist and hand. Shoulders, 5 to 7 per bone. And I don't have any reason to do that except for my own anecdotal experience. And that's what we're all relying on.
Sure.
And you ask these questions, you know the answer to these questions, Alberto.
Yeah.
Mostly because we grew and developed a lot of these things together.
Sure.
What needles we use, what all this stuff we use. But in general, for a larger subchondral, for a larger bone marrow lesion, I'm going to use a higher volume. For a smaller lesion, I use a smaller volume. What's a larger lesion? Well, the Hernagu studies, I think it was 4 cubic centimeters was his cutoff. I don't have the software, but I can roughly eyeball that. You know what a large one is, you know what a small one is, and then there's a smaller area, medium-sized. And so for small ones, I'll do 2 milliliters for a real small one in a medial femoral condyle, and sometimes I'm going up to 10 milliliters for a real large one.
And now, in terms of leukocyte-poor or rich, if you have a preference, and I hear you, I don't think there's any data kind of either way, right? I think the concept is potentially leukocyte-poor would be a little bit gentler on the bone, and leukocyte-rich, the proponents of it would say, hey, it's an area of necrotic bone almost. It's kind of in this stage of, basically it's not dying, it's not growing, right?
Yeah.
It's in purgatory. So put the white blood cells in there to stimulate a response, right? And I don't think we know. But if you have to choose, what are you going to go with most of the time?
Yeah, I generally go with leukocyte-rich.
Okay.
Only because you get more platelets.
Got it.
And for other body parts, especially tendons and intra-articular use, we know that up to some point, we haven't really found the ceiling yet for either, but we know for tendons, we know for joints, more platelets is better outcomes.
Sure.
And that's all the data we have. I don't have any more reason to say more platelets are better for intraosseous, otherwise, other than just extrapolating from my tendon and joint protocols.
Yeah.
So I don't really have a preference if there are white cells or some red cells in there or not. There are white cells and red cells in there already.
Correct.
So I'm not shy about putting more in there, but we know we'll get some 10 to 20% more platelets if I put it on a leukocyte-rich setting.
Yeah, I've gone back and forth. I feel that, as I mentioned, I prefer bone marrow concentrate. Bone marrow concentrate has a ton of white blood cells, more monocytes if we're being fair. But it's like, well, I can't have it both ways, right? I can't say bone marrow concentrate is probably better than PRP and it's leukocyte-rich, but then PRP I'm going to take out, right? So that's where I've kind of landed on it. But I've also kind of, for the most part in joints, still tend to be a leukocyte-poor guy. I agree that we need higher doses of platelets, but I've gone back and forth, and I think maybe that's a cool study to do, right? So characterize the PRP a little bit better when we do an IO study, right?
I don't disagree with any of that stuff. For joints, if I had a choice for most things, if I had a choice, the same number of platelets, let's say 10 billion platelets, one was leuc reduced, one was leuc rich, I would probably err on the side of leuc reduced only because there's going to be less of a pain flare-up afterwards.
Yeah.
We don't really know that leukocytes are helpful or destructive, but they do cause a flare-up. They hurt.
Yeah. Now, we talked about what you do or which indications you like to do intraosseous. What are some pathologies that you're like, hey, this is a little too much for an in-office injection? They should probably go to the OR. It needs a decompression. Where's the threshold where you say, hey, I'm going to refer this out?
Well, my main indications, my main contraindications are malalignment because that's the number one contraindication because we have evidence mainly from Hernagou's studies that malalignment is a negative predictor of outcomes for intraosseous bone marrow concentrate. The other relative contraindication from studies is a large bone marrow lesion. People don't do as well if they have a larger bone marrow lesion. And over the last 2 years, I've been toying with this. In individuals with a larger bone marrow lesion, I counsel them that this isn't going to be one treatment. I'm going to go ahead and include an intraosseous PRP about 6 months follow-up after your initial bone marrow concentrate. And I would say that has now bumped up my success rate to around the 80% or so that I'm getting with my intraosseous, with my smaller lesions.
I think another one is acute avascular necrosis of the hip. To me, that one, typically it's a larger area. I prefer to probably have a surgeon decompress that and put kind of larger volume of bone graft and PRP or bone marrow concentrate, which would probably be really painful in an awake patient the way I do it. So that would be one that I would also probably refer out personally.
Let me ask you, how do you do that for a hip?
Well,
how would you approach?
For a long time, I was trying to go through the greater trochanter and make it all the way across. And then at one of the labs, I saw you do one, and you're like, no, just do it like this. Use ultrasound and fluoro. Kind of take that same approach as if you're going to do an ultrasound guided injection into your recess, and just go take an approach into the actual femoral head, and you're going to be right there. And then once you're in, follow it with fluoro. And that's made it so much easier. And I am no longer so concerned. As much as I know about orthopedics, I'm not an orthopedic surgeon. I don't do hip fractures. I don't pin hips. Right. So making sure that I get that trajectory through the greater troch and not go anteriorly and hit any of the neurovascular bundle, right? That's the thing I'm more concerned about. So switching to your technique has made it now where I can do it pretty much on every hip if I want to.
I'm honored and flattered that you.
It was game changer.
I'm taking so many things from Alberto.
Yeah. Now, okay, so we talked about which ones we wouldn't do, what we would do. Let's talk a little bit about bone graft, right? So that was kind of the, for all those who don't know, PRP, bone marrow construct, are FDA approved, but their single FDA approval is for the creation of a bone graft. Most of these other things that we do them for, like arthritis, tendinopathy, is off-label, but that was actually PRP's original goal, was to create this bone graft, right? So, have you used bone grafting? Do you still use it? What are your thoughts? Do you need to do that in the office?
Yeah, I actually haven't used DBN, demineralized bone matrix. I haven't used that with my PRP or bone marrow conjugate solely because we don't know that it helps. It might. My belief is that it certainly won't hurt. The indication where I would consider that, have considered, has been a bony cyst, especially a large bony cyst. I have taken my bony material from my bone marrow aspiration and put that back in my posterior iliac crest, and then put that in a knee or midfoot for a bony cyst. I've only done that a handful of times because I have concerns that there might be a little bit hanging out extra cortical outside what's going to happen. So currently I don't use much.
Yeah, I started most of my IOs, the first year I started doing them was with DBM. I felt in the office it was a little hard to get the right ratio where it would get a little too thick, and try to push that through an 18 gauge needle is impossible. So then I was using larger, 13 gauge IO needles. And, again, doing them in the office in an awake patient, that pressure of you pushing that in there is significant. Yep. And sometimes it starts to get clogged up. I've had a couple of syringes, kind of explode on me, and I was like, okay, this isn't fun. And I have also seen, to your point, which I think we'll get into a little bit later, is when you do use DBM and you don't wait for the stuff to settle and you just take the needle out, there is kind of this extravasation. And I've seen ultrasounds where I can see the DBM hanging out in the capsule, right, or in other areas kind of just outside of the bone where I injected it. I don't know that it really had a negative effect, but it's not something that I would prefer that it wasn't there.
Yeah.
All right,
Agree
so DBM, I think larger lesions, if you're doing it in the OR, probably a good idea. I think for in-office use, keep it to a fluid, and I think you'll probably be fine.
I agree.
All right, so let's talk about a kind of a debate we've had a little bit, is what needle do you use, right? Can you get away with just an 18 gauge needle? Do you need an IO needle? Do you need power? Kind of what are your go-tos?
I use an 18 gauge spinal with centimeter laser etched markings for almost every intraosseous case I use it. The laser etched centimeter markings are really important if you're using ultrasound. If you're using fluoro, well, you can see your depth. Mm-hmm. The needle has to have a metal stylet. Some spinal needles come with a plastic stylet, and that can break off. And then if your needle gets clogged, you can't declog it with a plastic stylet. I played around with smaller and larger needles, and for those of you who are not convinced that an 18 gauge can get intraosseous, the analogy is a drill bit. If you have a big old 1/2 inch drill bit and you're getting through a stud on your wall, it takes a lot of pressure, takes longer. Whereas you use a real skinny drill bit, you're going to go through quick. It's really the same thing with bone. So the smaller the needle, in my experience, the easier it is to penetrate the cortex. In my experience, a 22 gauge is about the smallest that I can use to go intraosseous without the needle twisting on itself. Not the bevel, but the actual shaft of the needle twisting. 22 gauge works just fine. I use 22 gauges when I'm going through an intra-articular part of a bone, such as a humeral head. A lot of times I'll go through an area of the humeral head where there's just no cartilage, so I don't have any concerns about damaging cartilage. I use 22 gauge just because it's smaller.
The damage is done.
It's
done. Yeah.
Right. And maybe they get a little microfracture.
Sure.
A 25 gauge, though, that's too skinny. The needle will twist on itself. I have concerns of that needle breaking. Haven't had it happen to me, but it is just less control over 25 gauge. So 18 for just about everything. Now, on occasion for a patella is the one bone in the body where I leave and my whole right side of my body is sore if you get an athlete, because it's a thick cortex.
So thick.
That's the only bone that I have a couple times turned to a drill, and usually that's with a 15 gauge.
And for patella, assuming you're using fluoro, lateral view going from anterior to posterior, kind of mid patella. That's what you like. Okay.
In fact, the patella, it's so superficial. You can feel medial, lateral, superior, inferior, and I follow my subcondylar edema on the MRI. So I go right where that subcondylar edema is on the MRI. I usually start, if I'm doing fluoro, I start with an AP view, so I can see where it's a PA view, so I can see in both directions where my starting point is, and then I immediately go to a lateral.
So something I've struggled with, and you just kind of brought it up. When I started doing IO, I wanted to be a sniper. Right, is I found the lesion on the MRI, and I was going to triangulate, and I was going to hit that target, right? Then I started reading that most of the studies were kind of not like that, right? Well, some of them were, right, like the avascular necrosis ones and things of that nature, but specifically the osteoarthritis ones, they didn't even get an MRI.
Procedural MRIs.
Yeah,
no MRIs.
They were like, hey, you have pain, you have arthritis on X-ray, I'm going in.
Yep.
So that's the shotgun approach, right? So what are you? Are you a sniper? Are you a shotgun now? How do you handle, or when you counsel a patient, if you see, for me, if I see the lesion, I'm going to try to offer them and offer my opinion that you need this. When it's arthritis and I don't know if there's a lesion or not, I feel a little more apprehensive to say, you need this. Yeah. What are your thoughts?
So we know that subcondylar bony lesion, bone marrow lesion, we know that is necrotic, fibrotic bone. Presumably, that's really our target. However, we also know that regardless of having a subcondylar lesion, that injecting intraosseous bone marrow concentrate improves their outcome over just injecting intraarticular.
Yeah.
So I try to be a sniper, but I do think that there is some room for not being for shotgun. I think there's a lot of room for that. For someone who can't get an MRI, I'll still do it. Absolutely still do it. And not rarely, probably once every other week, I'll put a needle into a bone without a subcondylar lesion, like you're saying. Tell me, what are your protocols?
Yeah, no, it's just that. Again, if one thing that I got from Luga was to use the tuning fork. And when I examine a patient with arthritis, obviously I palpate the joint line, go through all my testing, but now I'll bring the tuning fork, and if they have pain to vibration over the bone, then that's going to trigger me to probably get an MRI. And or if, like you said, for some reason they can't get an MRI, then I'm going to say, hey, this is the bone procedure. I think the rate limiting step is, do you offer it as a choice, right? Or do you say, this is the treatment, right? And that's the area where I've gone back and forth a little bit, where, I've gone through periods where I see the bone marrow edema. Okay, this is my recommendation. I'm going to do intraarticular, PRP bone marrow, and I'm also going to do intraosseous. It's either that's the procedure that you're signing up for versus, hey, we're going to inject your joint, right? You have arthritis, but also if you want, we can inject your bone. It's going to hurt like hell. And then all of a sudden the patient really starts to go like, well, I don't know that I really want to go through that, right? And also I think that's where orthopedic surgeons have such an opportunity to add the shotgun approach to their arthroscopies. The patient's already asleep, right? You do a meniscal root repair, a chondroplasty, any cartilage procedure. why wouldn't you? You're already there. Just inject into the medial femoral condyle, into the medial tibia. And we know the data's there that you're going to help with joint preservation. They're asleep. You can inject as much volume as you want. It's not going to change it. Because I think that's a rate limiting step for me, at least, is, well, I'm going to have, it turns into like an intraarticular injection is super easy. Yeah. Intraosseous, not difficult technically for me, but managing the awake patient through the procedure becomes, a thing,
It takes about an hour for me from entering the room to leaving the room for 2 or 3 bone intraosseous.
Yeah.
And if they're asleep, if they're already in position, if they're already sterile, much quicker. Yes, on all of those points, the surgical augmentation use, very exciting.
Yeah.
Not done enough. There is quite a bit of data. It works
to support it. Yeah.
And I'm excited to see more of our orthopedic surgery colleagues
start doing it.
Learning these techniques, learning how to really do a bone marrow aspiration, all this stuff.
And it's on label. I think there are ways to probably get it covered some of the times. But I think we agree on that. So let's hit on another point, because some of the viewers might be like, well, why don't you just numb it up, right? Or why don't you just do a regional block? And I feel like we've tried everything, right? We've tried, obviously you can numb the periosteum. They barely feel it when you go in. What they feel is the pressure of the fluid going in. I know you were big on regional blocks for a while, genicular blocks for the knee, and then you were even going higher, I think, subsertorius blocks, right? How are you thinking about that stuff now? What worked, what didn't work? Yeah. We also tried injecting a little bit of ropivacaine intraosseously, right? Where is that all at right now?
So I'll tell you what I do now, and then I'll go backwards. Yeah. Right now, I do no blocks for the knee.
Okay.
And I give people a couple milligrams of lorazepam, and usually I give them an MKO tablet, which is midazolam, ketamine, ondansetron. Works great, very safe. It's PO, it's sublingual.
Mm-hmm.
And 1 or 2 does the trick. We keep them in clinic. We dispense them in clinic. It's easy to do.
And how long, or how before you're actually injecting? How 30 minutes before? 10 minutes before?
5 to 10 minutes to kick
Okay,
in.
So it's kind of like right before.
I give it right as I'm sterile prepping. They're already marked. They're already numb as I'm putting my drape over their knee.
Got it.
That's when I give it. Sometimes it takes 15 or 20 minutes, but I'd rather it not wear off.
Sure.
I can always hang out for 5 more minutes if it's not kicked in yet. And that's it. I use 1 cc syringes. So if I inject 7 cc's of bone marrow concentrate, I'm doing them 1 at a time.
Okay.
And I keep a syringe of lidocaine. I use lidocaine and not ropivacaine just because it kicks in so fast. And it actually has a lower risk of systemic toxicity than ropivacaine.
Okay.
And if I have to, if it's really sore, I've got lidocaine. I'll put in 0.2, 0.3 milliliters of 1% lidocaine, wait 30 seconds.
Into the bone.
Intraosseous, into the bone, and then I'll inject. Now so going backwards, I've tried, I have researched and worked with regional anesthesiologist David Smith in Canada on regional blocks for all of this stuff. And so the knee is innervated by 12 peripheral nerves. It's called osteotomes. It's like a myotome or a dermatome, but osteotome. The innervation to a bone.
Yeah. There
are 12 peripheral nerves. No one in their right mind is doing 12 peripheral nerve blocks for lots of very practical reasons, risk, and so we're guessing they're overlapping osteotomes. We can take a guess at which one, and every once in a while we get lucky. With what I've been doing, it works. It's not great. It's the most painful procedure during the procedure.
Yeah.
The second I'm done, the second I stop injecting, their pain will go from a 7 or an 8 to a 2. And these patients all coming in well knowing that it's going to hurt for 10 minutes, 5-10 minutes per site. So going back, I've tried...
You tried it all. Yeah.
Everything. Oh, yeah. Boy. Obturator, accessory obturator, saphenous, through a deductor block, all of the geniculates. There's an IPAC block just proximal to the condyles.
Nothing works.
Oh my goodness, nothing really did the trick, and there is risk of doing these.
Yes.
I love blocks. I published on these blocks. The first article to be published on blocks for orthobiologics. For foot and ankle, popliteal block works great.
Okay.
For the shoulder, you can get by with a suprascapular block.
They do fine.
They do great. If you really want an extra block, do a suprascapular block and an axillary block. In clinic, do not recommend an interscaling block because there's risk of there's a higher risk of systemic toxicity as you get closer to the neck. For the wrist and hand, you can do 2 peripheral nerve blocks. Does the trick, maybe 3. And for the hip, you can do a ping block. For the knee, is the one joint, and of course it happens to be the joint that we most commonly want to put a needle into the bone. There's blocks are just, they can work, but they're just not as successful.
Got it.
My experience.
Now, let's talk technique a little bit. Ultrasound versus fluoro, combination of both. And then the way I've always conceptualized and taught intraosseous injections is I like to, I guess maybe one of the benefits of using a larger gauge would be to create a bit of a channel. My concern is when I've used contrast, trabecular bone has a mind of its own, right? Like the injected goes wherever. I'm in perfect position, but it's not going where I want it to go.
That's what happens.
Yeah, so I've kind of tried to go past it, create a channel, and then backfill the channel to at least, not guarantee, but feel better that I'm leaving it in the region. So what are your thoughts on ultrasound versus fluoro, and then your actual technique on and I'll take it one step further, ported needle with like side ports, closed tip, open tip. Do you have a preference on any of that?
My current technique is a regular old cheap 18 gauge spinal with centimeter markings, and for the most part, sometimes I use 22 gauge, and I use in an ideal world I would use ultrasound and fluoro. It's more expensive. I have fluoro at my surgery center, not at my clinic. I have the world's best ultrasound in my clinic, and I also have my lab in my clinic, and I also have my staff who have been doing this stuff with me for almost as long as I've been doing this and have gone to orthobiologics courses with me and on their own at clinic. At the surgery center, I have great staff. We have a good ultrasound, and we have a great C-arm. So it's a trade-off. For knees, the interesting point, fluoro for a knee or for a midfoot, and really, from my experience, for a shoulder, those joints, ultrasound can very accurately get your needle in place as long as you have, the only thing it doesn't do is your depth. Centimeter markings on a needle, that takes care of that. So I've done 50 plus cases using ultrasound confirming with fluoro. And no time have I ever had to move my needle.
Nice.
So I don't have any concerns about accuracy. It's a study I want to do. I just, busy with other studies. I have no concerns with my needle placement. The question is just what you said, Alberto. It's extra osseous flow and it's intravascular flow. Those two things happen probably half the time or more.
Did you notice the sigh?
It's tough.
It's exactly.
When I'm doing it with fluoro, the only reason to use fluoro, in my opinion, is to do a live injection under contrast with contrast. Has to be live. If it's not live, well, your IV just ran off somewhere. You're not seeing it. It could have. So the next. And so with ultrasound, you don't see that stuff. My technique when I'm doing it with ultrasound is I'll inject at 3 or maybe 4 depths. And usually my depths are 1 millimeter apart. So if I'm coming in from the medial to lateral for a medial femoral condyle, and my target lesion is 9 millimeters from the medial, the medial cortex, then I'll probably start injecting at 7, go another millimeter, inject at 8, go another millimeter, inject at 9, another millimeter, inject at 10. And not only will that probably help with just spread, but if there is some intravascular, then it decreases that risk. So concerns with fluoro. You got to use contrast, which is inhibitory to mesenchymal stem cells.
Sure.
We use it because it tells us where we are. It tells us what our flow is.
Yeah.
But it's in an ideal world, we just wouldn't need to use it. So I think there are a lot of questions that we don't know. One last point on that question. None of these randomized trials we're talking about used contrast.
Correct.
None of them used contrast. None of them knew if their flow is intravascular. None of them knew if their flow went right back through the needle tract like you suggest and went extraosseous. So there is some good argument that it doesn't matter if it's going IV or extraosseous because enough is staying in the bone to get the effects we want.
And correct me if I'm wrong, I think the Herningu study was fluoro, and then most of the others were ultrasound, correct?
The Herningus were all of the... Boy, they're all fluoro. The 3 Hernigus were fluoro. The 2 Barmans were fluoro. The Sioux was fluoro. Sanchez was fluoro.
They were all fluoro. That is right. Yeah, that is right.
Non-controlled trial, non-randomized trial was fluoro. And then the more recent Falardo non-randomized controlled trial was all fluoro.
All fluoro.
There are 3 that I know. There are a few ultrasounds. So yes, you're totally right. There are a few ultrasound studies.
But more fluoro.
But they're not the randomized controlled trials. As far as I know, you might be right on that. But as far as
I think I missed that.
And the ultrasound studies are cool. There's some very cool techniques that they use a needle like a 27 gauge.
They really just kind of try to get it in.
They find a little capillary channel and then they just use that to get intraosseous, and then they inject with a 27 gauge. Right. But my problem with that is getting the needle in the bone. They don't feel it if you put a CCL lidocaine on the periosteum. That's not the problem. It's injecting into the bone that is going to hurt no matter what size needle you use.
So we're lucky we have both ultrasound and fluoro.
Yes.
I get a lot of docs that come to the labs and they only have ultrasound. And what I tell them is, I think it's still appropriate to do, but you have to really just play it safe the whole time. Don't go more than 1 to 2 centimeters in the bone. Never take a steep approach towards the joint. Stay flat with your hands. Is that something you're seeing in terms of, hey, if you're just doing ultrasound, you can get in the bone, but it's just shotgun. Don't try to be a sniper. Just get some in and get out. Would you agree with that?
I would agree. I do almost all of my knees now with only ultrasound.
Okay.
So and I have access to both.
Yeah.
And the reasons are for all those things I just stated. Ultrasound, getting the needle in place is just as accurate, if not more accurate. And there are some reasons that it might be better to not use contrast. So now, for other joints, the hip especially, in my opinion, needs fluoro. The femoral head needs fluoro because it's huge.
Yeah.
Our femoral head is several centimeters in diameter, and if I'm on one side of the femoral head, what are the chances it's going to get 2-3 centimeters to the other side of the femoral head?
Yeah.
Which is the same reason I don't go through the greater trochanter through the femoral neck to get to the femoral head. Because I can be more of a sniper, and for the femoral head, I'll use 2 or 3 needles. If it's not rare for me to put 18 gauges into a femoral head to get medial, lateral, anterior, posterior. If it's a large lesion, the midfoot you could probably get away with just ultrasound. The shoulder, I recently have a preference for only ultrasound just because I did 10 or 15 ultrasound and then confirmed with fluoro. They were great. There's nothing to change about them. The ankle, I like fluoro. So the ankle and the hip right now are the 2 joints that I always take to fluoro. What are your preferences?
Well, I like the combination typically. I use ultrasound to first get an idea of where, for instance, on a lateral knee, lateral femoral condyle, I like to see where the popliteus tendon is at. I like to see where the LCL is at. I do all of that with ultrasound. And if I can approach the injection in a way where I don't have to go through those guys, I'm going to do it. Then I'll use it to do the periosteal block, and I get my needle in position. But then I double check with fluoro, and then once I'm in, I switch to fluoro.
Yeah.
The one place that I love ultrasound alone is insertional supraspinatus, like on the footprint where you see the, subchondral or subcortical cyst, or, there's bone marrow edema there.
Yeah.
And I'll just ultrasound only, inject into the tendon and then go right into the bony lesion. That's where I love ultrasound only. And then also there's times where, older females with osteopenia, osteoporosis, where, it's going to be so easy to get into the bone where I'll just, stay safe, with ultrasound and just go in and do it ultrasound only. But if I have my preference, if you're going to tell me, okay, what is the best approach for me, is to use both tools, right?
If I had in an ideal world, I would do what Alberto Panero does. I would have a C-arm right there, and I would just snap a confirmation picture with a little contrast for every intraosseous.
The contrast is funny because again, it has a mind of its own. And so unless I see some like ridiculous intravascular, this is no good, I'm almost like, well, I'm not really going to change much, by doing it. But so I've kind of stopped using contrast. What do you do at the end, right? Because obviously these are high pressure lesions.
Yeah.
Once, something that Luga kind of, told me to do is like, hey, just leave the needle there, right? Put the stylet in and just let it sit, maybe work on the other side and give it a few minutes so that stuff starts to clot. Because I have seen where when you take it out too early, and I've done them with contrast, you take another picture and then you see it start to flow out, right?
Oh, yeah.
Which also is another point, measure twice, cut once.
Yep.
If you start to poke the bone multiple times to try to get to the perfect spot, that's just going to flow all right out of the bone, right? So those two things, anyways. So the other solution would be to inject a little bit of thrombin and try to create a little bit of a plug. What do you do at the end? Do you just leave the needle in there? What's your strategy?
I 100% of the time will use either thrombinate or thrombin.
Oh, nice.
Autologous thrombin. Or I'll take bone marrow aspirate unheparinized, let it clot, which takes seconds, and it clots, and then I just put that in. I call it the chewing gum because you just want to put your bone marrow clot on the cortex. So I pull my needle 2 millimeters from coming all the way out, so it's right at the cortex, put in just a drop just to start and propagate a clot and just clog the exit. And then I leave my needle in for a minute, and you pull the needle out, and then I'll have one of my assistants hold pressure for another minute. And then at that point, I've tested it not very rigorously by putting my ultrasound probe back over, and I don't see it leak like I used to see it leak like you described. So I do that more than the other just because I've always got it's just easy to grab extra bone marrow.
I don't want to say it's a newer concept, but something that I've been trying to think about more too is once I'm in the bone, where we know there's a bone marrow edema, do you aspirate bone marrow to try to get that let's call it the negative bone marrow out, or would you consider lavaging with saline to kind of flush the area and then putting your biologic in?
I haven't tried the saline lavage. It's a really interesting idea. I think I'm one of the more rare people who aspirates. I take 1 to 3 cc from each bone, more for larger bones. And then right away, right after aspirate, you put in your first cc of bone marrow concentrate. Otherwise, your needle will clot. If your needle clots and you can't get it out, well, you can't use that needle.
Yeah.
And just like you're saying, if you got to put in another tract, there's a chance your bone marrow leads the first tract. So that's generally how I do it.
Another, I think, thing that I've learned from you is to be a little bit less conservative with the post protocol. I used to, like for the knees, I used to put them in a straight leg brace, non-weight bearing, right? I used to open it for passive motion, but in general terms, I was very conservative. I was very scared that if they put weight on it, they were going to have a collapse or another fracture or, whatever the case may be. And then I've started to become more lenient, where now I pretty much do weight bearing is tolerated. I do give them crutches. I do like adding an unloader brace, especially in the knee, to try just to, either way, I think it's a good idea for if I'm trying to heal the bone, take some pressure off of it. What are your thoughts on, well, I guess I just said your thoughts, right? But
yeah, well, we agree on most things
Yeah.
just because we fight things out
Yeah.
and we argue a lot over the phone at conferences. It's really nice to hear each other's logic. For this, the only reason that I can really think of to make someone non-weight bearing or partially weight bearing is if we're trying to grow cartilage, like a microfracture. But we haven't seen in studies that really happens.
Okay.
If it does happen, it's very little. Hernigu study showed 2% increase in cartilage volume. 2%. That's nothing. That's no practical amount. So because of that, I don't routinely. Occasionally in someone who's young, 20s, 30s, maybe 40s, and I really hope to maybe have some cartilage regrowth, I'll have them go partial weight bearing or non-weight bearing. But I'm still not seeing any routine, consistent cartilage regrowth. So I don't think it makes much of a difference.
What about the non-healing fractures? Do they immobilize those after your intrafracture injection, if you will?
Yeah. So those I've done tons of. That's one of my favorite topics. And those, once I inject, I essentially treat it like a fresh fracture. If it's a navicular fracture in the foot, well, I treat it like they just had an acute navicular fracture. If it's a pars fracture in the back, I put them on my 3-month return to sport protocol, which is a month total shutdown for 4 to 6 weeks with slow return to activity and physical therapy.
Now, last year, I want to say it was last year or the year before, you presented, you had the courage to go on stage and present your complications on patellar tendinopathy.
Yep.
This year, I'm presenting some of my complications with, ultra high dose intraarticular injections. Have you seen complications with the IO? What are you worried about?
Yeah.
Is it a pretty safe procedure for the most part?
Yeah. I need to give a little interlude here. Talking on your complications on a national big stage at the biggest and oldest first orthobiologic conference takes several qualities that you want in someone who's teaching you and someone who's treating you. It takes humbleness. It takes a recognition that these things happen. And if you're the best of the best, which Alberto Panero absolutely is the best of the best, these things simply happen, and you have to want to make everyone better and grow, including making yourself grow. I have so much respect for people who talk about complications, and when I have them, it's so important to talk about them, get them out there, and hear ideas on why they might have happened. Interesting thing and I promise I'll get to your question, but an interesting thing for us primary care sports physicians, PM&R sports, emergency sports, family sports, ped sports, none of us were trained in any procedures that had complications. We're not used to this stuff.
Right.
And even post-procedural pain. Now, our procedures have such low complications. I have never had an infection due to anything I've ever done to anybody.
I'll do it for you.
I had a DVT. I've had one DVT. And looking back, this lady literally laid in bed for, it was like 8 days, except for going to the bathroom with a boot on. Not after an orthobiologic procedure, after something totally separate. I've had 2 burn wounds, not from me, but from a hot pack that they put on themselves. And we got to learn to deal with these things. Now, intraosseous procedures, complications are unheard of at this point. There's not been a reported complication except for just pain, increased pain.
Or have you missed, right? I assume if you break if you what I say is like you're the complication, right? You broke through the healthy cartilage into the joint. You hit a big vessel, right?
And if you're using one of our techniques and you're really by the book,
happen. Yeah.
Boy, you've got to really mess something up to do that. So I have injected intraosseous in something around 1,500 bones. Not 1,500 people, but 1,500 bones. Probably averaging two to three per person, and I have not had anything close to a complication, just pain. I have had a handful of those people who hurt more than I expected for 2 to 3 days, and I had to use an opioid. Otherwise, I don't even give opioids. I'll give some tramadol.
What are some misconceptions? When I see, for the surgeons, IO, it's not, they just don't want to do it in the office, but they're not, intimidated by it.
Yeah.
When I see a lot of primary care sports come by to the lab, to my IO station, they get wide-eyed, they barely want to touch it. They're very nervous. It seems like it's for them very out of their wheelhouse. What are some misconceptions on maybe how hard this is or how easy it is to do?
The biggest misconception that I hear from my colleagues is that this is a risky, invasive procedure. And you already hit at that question. We don't know of anything more than pain as far as a complication. It's a very vascular structure. That means infection risk is very low. And other complications just haven't been seen, heard of. I haven't read or seen or heard of any DVT or any other complications whatsoever from intraosseous. Now, the other interesting misconceptions goes back to this first one that I mentioned. It is not hard to get a needle into a bone. It is simply not hard to get an 18 gauge needle into a bone. And I consider it less invasive than putting a needle into a tendon for a few reasons. Bones are so vascular. Bones heal great. You put a needle in a bone, there's no concern about that hole from your 18 gauge not healing. There really is no concern. The complication, the risks appear to be higher putting a needle into a tendon than putting a needle into a bone.
Interesting.
That said, putting a needle into a tendon is extremely safe. My presentation a couple years ago was one of the first presentations on complications that can happen from putting a needle into a tendon and injecting orthobiologics. The last misconception is really more of a ignorance, because so many people, sports physicians, and now I'm going to jump on my soapbox, Alberto. My biggest, thing I want to most get out to the orthopedic and primary care sports medicine world is that intraosseous procedures are out there. They're well studied with several randomized controlled trials, and they're easy to do. It's surprising how often our field doesn't even know they exist, or orthopedic surgeons, for whatever reason, think it's not quite invasive enough for them. Maybe we think it's too invasive for us. So it's this funny middle ground. But the truth about intraosseous procedures is that they are proven at this point to be knee replacement delaying or sparing procedures. They work.
If you want to learn how to do these, don't forget tomorrow we're going to be doing a huge lab with TOBI where it happens every year. We have several cadavers, several stations where you can actually get your hands on some of these tools and practice intraosseous injections. So a plug for the lab and a plug for ourselves, but certainly there is training out there, right? So you can go and get the experience here and in other labs so that when you come back, you can do it in your office.
Hey, Alberto.
Yeah.
Last year at the TOBI Cadaver Workshop, out of the 16 stations, which station did I keep having to pull people away from because they were just crowding around that instructor? Yeah.
It may be the IO station.
It was the IO knee led by Alberto
I was
Panero.
so tired after that one.
There were 12. We had a limit of 5 people. There were 12 people because everyone liked to hear Alberto's sweet voice, and he's a very good teacher.
Oh, man, you're killing me. All right, let's close it out here. I think we've given everybody some really good stuff. If you weren't practicing medicine, and aside being the head coach of the Chiefs, what would be an alternate career for you?
Well, right now, what I really love my career because this is the best, coolest field. How many other fields do you get to go to work and really help people and enjoy what you do, and then you get a paycheck for doing that stuff. But outside of that, I'd probably be a part-time gardener or farmer. And then what I really would want to do would be a volunteer at my kid's preschool and just kind of eavesdrop, just watch,
just hang out,
just see what he's doing.
That's awesome.
He's making friends. What's he up to today?
Yeah, that's awesome. Yeah, part of this journey, not to get personal, but it's been both of us having, going from like single dudes to married, now with kids. We're adults now. It's crazy.
Yep.
But all right, so if you could have any dinner with any historical physician or scientist, who would it be?
Yeah. Great question. It's hard to pick just one. I would want to talk with someone like Tesla or Isaac Newton, or someone who was just so motivated in his career to come up with new things that were game-changing for humanity on a big level.
Yeah, those are two big ones for sure.
I could name another 50, but I just want to know, how do your brains work? What motivates you? What people do you bounce your ideas off of? What are your habits?
All right, lightning round. Beach or mountains?
Mountains.
Early bird or night owl?
Early bird.
PRP or BMC? You can only pick one all day,
BMC.
right?
I love PRP, but you'd have to finish that question.
All right, and lastly, when they make the movie about you and your life, who do you want it to play you?
Well, this would be a much more smart and good-looking person in my place, but I'd probably choose Alberto Panero.
Oh, come on. I thought you were gonna say like Ryan Gosling or something like that.
Maybe Leslie Nielsen, the Naked Gun actor who just bumbles and trips and can't make a sense. That's probably more accurate.
That's fine, man. Well, this is awesome. I hope you guys enjoyed this. Please don't forget to like and subscribe if you like this content. Mike, truly an honor. Thank you for being here. Until next time.
See you guys later. It is a great honor. Thanks for having me.
See you next time.